floor is yours.
Thank you. Thank you. So it's an honor to be here. I think one lesson to take home from this, I'm going to talk about, well, how we've invested in new hospitals, and especially how we've invested in a new hospital structure. And the counterintuitive point I'm going to make is that we've made a huge investment and will come out with less beds than we have today, not more beds. And I think I will also go through my presentation, maybe trying to make some points that will tease you a bit or provoke you a bit, but look at it as an impulse and not me trying to be impolite. I hope you will see it in that proper spirit. So what I'll take you through is just a short introduction to our Danish healthcare system. It's a bit different from the German one, and of course Denmark is a much smaller country. We're only 5.7 million people. Then the story, why we did it, how we worked with our super hospital program, and then some more specific cases as to how does it work both inside the hospitals and outside of the hospitals, working with e-health, etc. Yeah, the Danish healthcare system. Wow. It's based on 4 fundamental pillars. It's universal coverage, it's free and equal access, it's financed by general taxes, and it has, so this is a public paid system. Huh? This is a difference from your system. It's not a single payer system, but it's a publicly paid system. It has a relatively high degree of decentralization. At the national level, the state level, we set out regulations, we set out incentive structures, we set national guidelines, national goals. We also have an agency for health that places our highly specialized treatment. If we have, heart diseases for children, how many places in Denmark should you be able to go through with such an operation? We have a national authority that decides how many places this should be a possibility and where to put those operations. But apart from that, our hospitals are run by our regions. They have politically elected leadership. And it's their main task is to run our hospitals. We have 5 regions. They don't have a right to collect taxes. They get a lump sum, a yearly, bag of money to go through with their tasks. But they do hospitals and they do our general practitioners. And then thirdly, we have our local municipalities, almost 100. And they take care of prevention and rehabilitation. They have the right to collect taxes. So this is on the one hand, this is a coherent system, but at the same time, you have different players with different incentives. We have that mechanism in Denmark as well. Before we go to the hospitals, it's of course very important to mention that we have general practitioners, family doctors. Each family doctor has approximately 1,600 patients attached. And our general practitioners takes care of approximately 90% of all contacts with our healthcare system, that being email or phone or personal contact. So you cannot just go up to the doorstep of a hospital and expect to get treatment. This is very important. When I'm in a while, I'm going to say that we want to put the specialists in front. You have to remember that there's a gatekeeper mechanism for the system. How do we spend our money? 75% approximately goes to the regions, covering our hospitals and our general practitioners, medicine grants, and approximately 25% goes to our local municipalities for rehabilitation and prevention. How are we doing compared to other countries? We are not the cheapest system in the world, but neither are we the most expensive one. And how are we doing when we look to results? You can compare systems, of course, by looking at different figures. I took this one out because it's the argument I'm going to try to make, that when we look at length of stay in hospitals, Denmark is doing comparatively well. We are down to, this is 4.3 days. This was back in 2013. I think now we're down to 3.6 days, and some places even below 3 days. And we don't kick out the patients. Our patient satisfaction is still relatively high. So we've managed to have a very short average length of stay. This is to keep in mind. When we look at how Danes are living, our life expectancy, it's not as good as compared to other countries. We drink too much, and we smoke too much, and we don't exercise enough, and we're not able to detect cancer as fast as they are other places. So, I mean, we are struggling with a lot of things in our system, and we have, as everywhere else, we have a rising number of people with chronic diseases. So this is the backdrop. Now we go to our super hospital program. We go back to 2007. Back then, we asked ourselves the question, what kind of hospitals do we really have in this country, and when did we build them? And we drew that in a map, and we realized that the bulk of our hospitals, they were built back in the 60s and the 70s, and we thought to ourselves, well, if these hospitals, you know, what are we going to do 20, 30 years from now? Will these hospitals be fit for purpose looking into the future? And people said, well, they probably won't. So we will have to make investments in new hospitals anyway. And if we're going to make those investments, and it's going to be significant investments, we might as well try to coordinate our forces and our resources and turn that into a coordinated investment so that the hospitals we will be building will be built for the future and not resemble the ones we have today. So what will the wise man do? We asked our agency for health and experts surrounding that agency to come up with characteristics of such new hospitals and such a new hospital structure. And they said, firstly, we have to look into our hospital structure. At that time, we have hospitals that cover areas of approximately 150,000 patients, and they said the average hospital should probably cover closer to 300,000 patients. And this is due to the fact that we're going to discover more types of diseases. We're going to give more specialized treatment. If clinicians are going to give treatment to a proper level, they will have to have an inflow of patients with many different diseases. They will have to be in environments working with research, and they will have to have a lot of colleagues. This is an environment to provide proper treatment, and it will be a nice environment to work in as a clinician. So this is really the basis of this. This is a new hospital structure, and we also need new equipment, and we cannot buy this 100 times. We can only buy it maybe 10 times. So also for that, we need stronger facilities. At the same time, we want these hospitals to function with another type of organization than at least the one we have in Denmark. In Denmark, it's so that if you arrive at the hospital, you will be met by, it's pretty chaotic in an emergency ward. There'll be a lot of noise, and the physicians working there will be the least routine. And once you get the routine, once you become a proper specialist, you will move upwards in the building to get your own specialty and more, you'd have more calm on your wards. But these people, they said, we have to have the most trained specialists. We want to have them down in the front where the patients arrive. We want to have them there to put up fast and proper diagnosis, so that we don't have patients spending time in the wards of the cardiovascular diseases, and the next week they'll be up with the people working with neurology. We have to make the samples, and we have to cooperate all at once. Of course, the clinicians or the physicians, they didn't like this to begin with, but we've started working like this in Denmark, and there's a clear evidence that this gives a more coherent patient treatment, and they're starting to enjoy it. So this is the second thing. And the third thing, of course, is if you want a new division of labor with hospitals located further away, at the same time you want a stronger pre-hospital care, faster ambulance services, and also a better care for everyday life situations, like Kathleen mentioned, that you should have more tasks that could be solved at home. If you do these things, you will succeed in having a system with better and more coherent patient flows, faster diagnosis, better patient treatment, better learning environments for your physicians, and better use of your resources to the benefit of taxpayers. Okay, so this was the idea. With this vision, we said, we'll do the investment, but how to invest? Because this means that you have to close down hospitals. And nobody's going to close down hospitals. Not to begin with. This is, you don't do that. And this is the same case. The case is the same in Denmark as it is in Germany. The hospital is the pride of the city. This is where people work. This is where they have their lives. You cannot close down a hospital. But I think there were two things that made a difference. The first thing is that we have a lot of figures showing us that the mortality rates at our smaller hospitals were bigger than the ones at were higher than the ones at the bigger hospitals. So if you want to be hospitalized, you want to be hospitalized a place where physicians know what they're doing. And people accepted that as a premise. The other thing was that we put down the money. I don't know whether there's this thing called the Honeypot Principle, but the idea is you put forth the money and you say they're here, and you could get access to it, but only by adhering to certain criteria. And these criteria were set up not by politicians, not by government, but by a team of experts. So the criteria were would you say they were not accepted by all, but they were objective and they were transparent. And in this process of putting forth the money and putting forth the criteria and then asking our regions, which hospitals are you going to close down? Which one do you want to invest in? Do you want to modernize the ones you have, or do you want to build new ones? You cannot get this big a hospital. There's only that amount of money. And in that process, in that modeling process, we came through with the hospital structure that was both acceptable as an overall picture and was also acceptable for the regions. So you, in this process, you were able to make some, I think, very tough political decisions that would otherwise not have been made. And Claudia Schiffer is there to symbolize the beauty of these projects that came out of it. 60 new projects as a total. This is each project. It's a fixed amount of money that they get each project. The regions are not allowed to invest any other money in what they've told us that they're going to build. This is they have to keep their beds down. I'm going to get back to this. They have to keep some of the money for investments in equipment, and they have to. A year after we've inaugurated these new hospitals, they have to give 5 to 8% of their running budget back to politicians, the regional politicians and the governmental politicians. And this is to create a driver saying that if you have new buildings, and we have invested in these new buildings, you're not going to do like you do today. You're going to have to do better. Yeah. So are these hospitals, are they going to be big enough? There's a lot of worry as to how many beds will there be in a hospital, and is a bigger hospital better than a smaller hospital? And we have this discussion that maybe the potency of a hospital should not be measured by the size of it or the amount of beds that it has, but it has to be measured by its capacity to deliver patient treatment at proper quality and cost. And so we try to work with this changing mindset. So how far are we? We're in the midst of this. I'm not here telling you, we did it. We can't say that yet, but we have all the projects in place. We're using our money, we're building. There's still some discussion as to whether are the budgets too tight. Will the hospitals be big enough or not? But little by little, we're building them, we are starting to use them, and we are inaugurating them. This is our Crown Princess inaugurating our first psychiatric hospital as one of the, well, that was the first of our projects here, and it is a psychiatric hospital in Slagelse. We are very proud of it. Yeah? One thing is, can you keep your time and your budget? Another thing is, of course, what were the assumptions made back in 2007-09 as to what would be the development in treatment in years to come? And one thing the expert said was that looking into the future, we'll have more outpatient treatment, and we'll probably be able to reduce our number of bed days. And as you can see, the development so far has been as expected. And we have physicians in Denmark saying this cannot be true, because I know that there are going to be more patients with COPD, cardiovascular diseases, cancer, etc. We are going to have to need bigger hospitals in the future. So we tried to dig into the figures, and what you see here is that even though the total number of patients with diabetes and COPD and cancer and cardiovascular diseases have increased, the total number of bed days needed has declined. And of course, there's no way to say that this is a development that will continue 10 years from now, but I think that there's nothing saying that it shouldn't. We are constantly improving our methods for treatment, our ways of communication, our ways to segment between patients and their needs. So we think this is a trend that will continue. This is a provocative slide, I think you might say. This says, you should be looking for Germany in this slide. The idea is, what is your number of specialists as a ratio to your beds, and what is your number of bed days as a ratio to physicians per bed? And this slide says that in Denmark we have nurses and doctors like tumbling over the beds. There are so many nurses and doctors there. And this is only efficient if we can make them work really fast. Apparently we can. But it looks as if in Germany you have, you're a bit more conservative when it comes to spending your resources on physicians and nurses. But what you should realize is then that it gives you longer bed days. So there's a balance here. I'm not talking about making a system that is cheaper, but I'm talking about how do you spend the resources you put into it. Yeah? Ideas on how to do this. We have this idea that fewer beds can create more quality. How is this done? We say that faster diagnosis, the right treatment the first time around, a flexible use of beds, and maybe even single bedrooms. That will reduce the number of bed days. It will lead to more outpatient treatment, and it will lead to fewer readmissions. So this is kind of a positive quality circle movement that we're trying to run. Yeah? How do we do it? How am I on time, Helen? I'm fine, okay. This is to say that we start treatment, if hospitals will be further away, maybe even an hour away. We don't have hospitals 3 hours away, we're a small country. But maybe it's an hour away. So we'd have to start treatment once the ambulance arrives. The ambulances we have now, they can access current medication data, the electronic patient journal, and they communicate with the hospital so that they put in place the operations, or there's things that should be in place when the ambulance arrive at the hospital, and they can start proper treatment already in the ambulance. And within the hospitals, we have done a lot to work with digitally supported communication when it comes to electronic boards and communications, both within the ward and also between the different wards, to all the time to really have fast-tracked and shared communication as to what will happen with this patient. This is about reducing your time in your processes. And then there's this one. And we have some of the hospitals in Denmark today that have single beds. Most of them have 2 beds or 4 beds. But this was really, when we had the vision of a super hospital program, when I started working in the Ministry of Health, I said, well, what is a super hospital? What does it mean? And they said, well, it means that you have a common emergency ward, and it means that you have single bedrooms. So those are like the 2 defining characteristics. And it's of course because we think that if you have, I'm getting an echo, that if you have single bedrooms, you can provide better treatment. So this is a bit more expensive to build, but it's probably less expensive to run it, if you know what you're doing. This one is to say, I mentioned that we put in efficiency gains on 4 to 8% as a demand in the hospitals. This is something that especially the hospitals and the regions, they don't like it. And to begin with, they said, you are insane. We're already building our hospitals smaller as it is. We cannot deliver efficiency gains. But then little by little, they've accepted this premise. And the trick, of course, is to try and take the organizations that they have today in existing plants and put them to work and working with new ways of thinking and solving their tasks, so that once the new buildings are there in place, the old organizations will have transformed and you will have new processes to put into these new buildings. So there's a fit between architecture and organization that you have to work your way around. And we use this 4 to 8% of efficiency gains as a trigger for that, as a driver for organizational change. This one is just examples of what we're doing. We're working with logistics, fully automated sterile goods management, systems for sampling and analysis. This is to make you that run hospitals think, oh, so this means that if I get a bigger hospital, I can invest in more equipment. Yes. Yeah? Then this one. This is not an official Ministry of Health slide. This is me trying to think about what Catherine talked about, actually. The thing is, when you think about what is a hospital a place that is, you know, self-sufficient and the world can fall apart outside of its walls? Once you are there, you're safe, you'll get your treatment, and if there's one thing you want to stay in that hospital, both as a patient and as a physician. Or could a hospital maybe operate more in terms of a lighthouse and be a place that provides guidance and security for people working outside of its walls, and also maybe for patients? I think this is a way of imaging the whole e-health and connected health debate. And examples of this, it's like what you talked about, Catherine. This is one example of nurses, local municipality nurses, that by the simple use of an app and a shared patient journal on ulcers can give better treatment to patients. These patients no longer go to outpatient treatment. They are treated at home, but under the guidance and supervision of specialists in the hospital. And our nurses, they really enjoy this because it gives them, would you say, more capacity in their daily work. Another thing is we call it patient-reported outcome data, patient-generated data. We use this as a way to check which patients we want to see for outpatient treatment. A patient shouldn't go, you know, every 3 months to routine checks. A patient should only go there if it's needed. And half of the patients, at least on some of the diseases we've used this in, they don't have to come. So this is a way also of optimizing your facilities. Yeah? And last, of course, you have to communicate securely and digitally with your general practitioners and the nurses and your patients and whoever you communicate with. Final slide. And this is just to say, if you want to invest in your system, you have to have a balanced look on what you're doing so that you will both be investing in your hospital, in your high-cost hospital, and in your high-cost patients. But at the same time, you should balance that also with investing in your low-cost patients, of whom you have many more of them, and you have to find like a bimodal system that can balance and cope with both entities. I think that it will be like the prerequisite for us if we should have a sustainable healthcare system also in the future, and have societies that are, you know, good and safe places to live in. Thank you.
Thank you, Nanna, for this excellent presentation. It also gives me hope as a former Director General in the Federal Ministry of Health. I have a lot of experience of failure and disappointments, and especially in the field of hospital care, where in our country the state governments are responsible for planning and investing. They always plan, but they don't invest. It's one of the biggest problems, I think, in our healthcare system. And the strategy, the approach, reminds me to Eugen Münch, who was the founder of Rhön Klinikum, a private group, which started some 30 years ago with the same idea to invest into modern hospitals, to give money to improve quality of care, to improve the processes, and to show the public that every kind of hospital can be able to be transformed from a castle to a modern lighthouse in that system. But we have also room for 1 or 2 questions. Please, feel free.
I do have some questions, Can you hear me now? Yeah, you can hear me. In Germany, we say that we have too few doctors because we have so many hospitals and we have so many practices over the country. So how is the development in Denmark when you close down hospitals and concentrate it? So is there any shift or do you have the same number of doctors, fewer doctors? How is it? Is there any shift you can see?
I think you can certainly say that the structural change is a way of coping with this question of how can you make sure that there is a sufficient number of doctors, and how our problem is also that they don't want to live in rural areas. So the smaller hospital in the rural areas, they have problems attracting physicians. So we'd say we'd rather put them into bigger hospitals and then transport the patients, but only the patients that need the transport. That is why you have to combine it with an e-health perspective.
The same problem as we have in Germany.
Yeah.
Last question.
And I know they know already.
To reap the benefits of this super hospital system, I imagine you will need a high degree of standardization in procedures, treatments, quality systems, etc. What is your take on that?
Well, you have to have the systems you're using. They have to be standardized, and they are. We have one ERP system already per region, and you have to have, of course, standardized procedures within your hospitals. But I think that making these bigger hospitals, that is a process of standardization in itself. So we combine this with standardization, but it's not an integrated part of the program. I think this is really about also keeping decisions at a local level, saying to the hospital and the hospital management, you have this bigger plant, make it work the way you see fit. But of course we have to standardize, or the idea working with the common emergency wards, there we standardize some of what we're doing, but really it's more a philosophy than it's a strict regulation. It's a way of thinking, and then they try to implement it in the hospitals. You have to balance, what comes from above and what is growing from below. Yeah?
Thank you very much. Our third,
Yeah, thank you very much. Just one question. How did you manage to keep the politicians outside from this approach?
No, but the whole idea of this is really important. This is the Claudia Schiffer point. If I can get back to her. No, I can't. The point with her, the point is that the politicians weren't outside of it. This is a political process, because it's the politicians that make the very tough decisions on closing down hospitals. So this is not a technical process and then politicians enter. This is a process where you put up some. Can you hear what I say if I talk like this? Yeah? You put up some criteria, some standards that are transparent, and they're there, and like a target. And then you have regional politicians discussing and trying to run for that target. So they were competing amongst themselves as, yeah, it's a kind of competition. But it wasn't the Ministry of Health that decided, here we're going to put the hospitals in these areas. They said we want it to be more or less after these criteria. So how are you going to live up to that? Adhere to that. That makes sense?
Makes sense, but I think it's also part of your political system in the end, isn't it? It's not about the ratio of the politicians themselves, how they behave and so, but I think it's a mixture, isn't it? Danish culture, maybe?
I think that Danish culture is very similar to German culture, if I may be frank. And politicians, I think this is about incentives. You shouldn't copy this, but you should get the idea of, it's a toolbox for you.
But you are within the revolution, and we talk on the revolution.
Yeah.
So again, thank you very much.